This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Welcome back to another interesting and an unusual case. So don't miss this one. I'm just ready to implant the lens. The cataract is out. I'm just trying to clean the posterior capsule by irrigating BSS. And at this moment, we can see that there is a demarcation line which is seen. It looks like it's a map-like structure and also looks a little bit oily. From the outside, it looks like OVD, but it is not getting disturbed by injecting fluid. So obviously, it is not in the antechamber. It's not in the capsular bag. It looks to be behind it. Well, maybe I thought it's OVD which has gone behind it. It looks like that. So let me go back and fill the antechamber with OVD and time to implant the lens. So lens is implanted, lens is in the bag. At this point, we can see that the pupil is regular, round. The capsular rhexis margin looks alright. There's no distortion of the rhexis margin. And I'm trying to remove all the OVD both in front of the lens and behind the lens. So at this point, most of the OVD is out and I'm trying to irrigate to the main incision. And we can see that the map-like structure which was there behind it still persists. So we are seeing OVD and a small lens particle, possibly in the burger space. And what does this indicate? Well, it indicates that fluid and OVD has got access to the burger space. And as I'm trying to irrigate, so when we have diagnosed a fluid misdirection, it's a duty now to find out is there something else which is wrong. So as I'm irrigating, I can see a tiny fiber fluttering here. What is it? It's a lens fiber or is it a vitreous fiber? So let's go back and check it by injecting diluted triamcinolone acetate. Well, it's like identifying the thief. And most often than not, we'll be surprised that how easily we can miss these vitreous fibrils. As we can see, is definitely much more than what it was visible before staining. Okay, time to perform anti-vitrectomy. Now, what would be your options? Would you want to do a translimbal vitrectomy or past plan approach? The patient is under topical anesthesia. So if we want to do a past plan approach, again, we have to maybe augment anesthesia. So usually I prefer to go the translimbal way. And if it doesn't get sorted out by this, then maybe I would like to go ahead and augment a little bit of anesthesia by giving subtenance and then considering past plana approach. Now with the irrigation in my left hand, I proceed to do the vitrectomy. First the vitreous at the wound is taken care of. Then the cutter is introduced inside and the vitreous fibril, which is very much visible, is cut. Now a few points to remember here. Dealing with the transzonular prolapse vitreous is difficult simply because we need to work very close to the pupil and the rhexis. There's always a risk of, the cutter cutting the edge of the pupil or the rhexis margin. So I need to be very careful. When I'm working very close to the pupil, I prefer to keep the cut rate in a linear mode so that I can cut only when it is required. To begin with, the cutting is done in a cut aspiration mode. And once, if I'm dealing with the one single strand of vitreal fiber, I change it to the IA cut mode. That is, first aspiration is done, you hold the fiber and then give a cut. Please note that when I'm working very close to the pupil in the far extreme, I usually prefer to keep the bevel away from the iris so that I don't cut the pupillary margin. And little bit of patience is required because you think that you're taken care of all the vitreous and suddenly you find that the vitreous is sneaking in from some other quadrant. This is a very regular scenario when we're dealing with a transzonular vitreous prolapse. Again, be patient. Go back and redo the staining if required and then proceed to cut. Sometimes it would be frustrating to deal with these individual vitreous fibers, but that's a challenge. So you keep on identifying them and trying to cut. And the principle is, if you don't allow the chamber to shallow, further prolapse of vitreous across the zonules can be minimized. So monitor the chamber pressure adequately. Now I'm sure that no more vitreous is going to prolapse out. This is the time when I'm going to inject a little bit of pilocarpine to get the pupil down, and also to note that I have not missed out on any vitreous fiber more. Of course, I would always reconfirm with the diluted triamcinolone acetate, but lens is well centered. The rhexis shape continues to be good, seems to be alright. The side ports are hydrated, and these are the first day post-op pictures. Well, so now let us go and ask the million-dollar question. That's the transzonular vitreous prolapse. Why did it happen? So let's rewind and see the case. This case looks like a routine one. Pupil is well dilated, there is good red glow, and let me take you through a fast scan of the video if something abnormal is seen. The rhexis is alright, hydrodissection is done, the nucleus rotates well, and all the maneuvers are as good as it can be. This is the last fragment which is phacoed out, and as soon as I come out, on the hind side, if I look at the replay, you can see that there is some wavy structure already present behind the posterior capsule. So my assumption is that the OVD has already entered behind it, and only thing is I saw it a little bit late. So the cortex aspiration is done, and by this time that the visibility of this OVD behind the posterior capsule is much more clearly visible because of the enhanced red glow. So the moral of the story was, even though there is no evidence of any zonular weakness, but this patient clearly had the loss of zonular barrier, which is going to compartmentalize the antechamber and the structures in front of the lens from the Berger space. The barrier effect had gone, and that's the reason why the fluid had got direct access into the Berger space. It's very common to find tiny lens particles in the Berger space, which are indicative of the loss of the barrier effect. But in this case, what was strikingly different was the presence of OVD, and probably it has gone behind the lens very much early in the surgery, because immediately after the nucleus was emulsified, there was a hint that the OVD is already present there. During subsequent maneuvers of shallowing of the chamber and deepening of the chamber, the antihyaloid did rupture, and that's the reason why we had vitreous prolapsing across the zonules. Later on, when we asked the patient, obviously he did not give any history of trauma, and there's no visible evidence of pseudoexfoliation or zonular laxity. So this case was a surprise and teaches us of the fact that we still don't know a lot. And the zonular barrier effect, which compartmentalizes the structures which are anterior to the lens from the structures which are posterior to the lens, is actually very flimsy, and this barrier is more in our head than actually it is, because I find this phenomenon of fluid getting access to the Berger space relatively quite common. But all those eyes usually have some sort of cause of generalized zonular weakness like pseudoexfoliation. But in this case, there wasn't anything which was evident. That was it. Thank you for watching and hope you found this helpful.